Hello, and welcome to the ALCSI podcast, where we share the stories of lung cancer patients and their caregivers, as well as the work of doctors and researchers in the field. Today, we have the great honor and privilege of having Michelle Ottersbach with us. Michelle is a nurse navigator, exercise physiologist, lung cancer advisor, and lung cancer screening program consultant who has worked in various healthcare systems, nonprofits, and NCI comprehensive cancer centers. In 2012, she found her life calling in lung cancer when UC Health University of Cincinnati Cancer Institute asked her to help them transform their lung cancer screening research study into the first structured multidisciplinary lung cancer screening program in the region. She currently works as a nurse consultant at UNC Lineberger Comprehensive Cancer Center. Michelle, we are so honored to have you on our podcast today, so thank you for your time.
Thank you. It's an honor to be invited to speak.
Wonderful. Well, to introduce our moderators today, my name is Priyanka Senthil.
I'm Jacob Rashap.
My name is Pranav Mandyam.
And I'm Sam Schwartz, and we are with the American Lung Cancer Screening Initiative, a national 501c3 nonprofit working to raise awareness of lung cancer and lung cancer screening. So to start us off, Michelle, can you tell us a little bit about yourself?
Yeah. I started my career off as an exercise physiologist, and that's where I worked in cardiac and pulmonary rehab with disease management prevention. And when I was working there, I realized the cancer population didn't have the same access to resources, so I transitioned into cancer wellness, cancer rehabilitation, and survivorship. Went back to school and got my nursing degree. And after I got my nursing degree, I got invited to help the University of Cincinnati to start up the lung cancer screening program. And I fell in love with the lung cancer. I fell in love with the lung cancer community, from early detection, prevention, through survivorship and end of life. And I've been doing that since I graduated from nursing school.
Yeah. So, Michelle, you work as a nurse consultant and a patient navigator. What are some of the responsibilities that entails?
Yeah. So as a nurse consultant, I'm helping to build out the multidisciplinary lung cancer screening program at Lineberger. In terms of patient navigation, what that entails is you go from the outreach and where you're going out to recruit people into the program. If they're eligible, try to enroll them into the program. You do your intake, and then making sure that their primary care physicians or their physicians are aware they're in the program, and then you make sure they get screened, and when they're enrolled, get their scans, quality metrics, make sure they receive the highest quality of care. Reporting results back to the patient and the provider, scheduling the next follow-up, and then calling them back for the reminders and keeping the cycle going. As a navigator, they're the most essential component of the entire lung cancer screening process. It doesn't have to be a nurse. It can be anyone who has the ability to move a patient through the healthcare system. So if someone doesn't have a primary care, you help them get enrolled. Scheduled for the new primary care. If they don't have health insurance, you help them enroll into a health plan or financial assistance. If they encounter any type of barrier, financial or anything, you're there to help every step of the way. You're reassessing their smoking history, so it's opportunities throughout every step to encourage smoking cessation and keep them focused on their health goals.
That's amazing. And can you share a little bit more about lung cancer screening program at UNC?
Yeah, the lung cancer screening program at UNC is the largest healthcare system in the state of North Carolina. It's a public healthcare system. The program is working on making it a more centralized approach to make it easier for the patient and the providers. You go to your primary care. You want to make sure that they're aware the primary care and the patient talk about the lung cancer screening to see if something they're interested in. If they're interested in, they can they'll refer them to the program to complete their lung cancer screening and any of the follow-up, and make sure they come back for follow-up and get the primary care, the results back. And so you help track the patients for the primary care or anyone else who wants to refer the patient. So you help track the patient to help them return. So that's helpful. So it is more of a it's more of a centralized but decentralized access where people can order, providers can order on their own, or they can refer to the program and they can take care of the shared decision making. So more of a centralized hybrid approach to lung cancer screening.
Awesome. Thank you so much for sharing, Michelle. And I think patient navigators are really critical to the success of a lung cancer screening program, because even if a program exists, it's as you said, the patient navigators that do the intake, that help schedule a scan, that communicate with the PCP. So what you do is so integral to the whole screening process. And I think it's recently a lot of screening centers have put a lot of resources and effort into building up their nurse navigators and patient navigators, but there hasn't always been this level of attention. And so we're just really excited to have you here on the podcast to share a little bit about what that perspective looks like. And so along those lines, can you explain the typical process and timeline for scheduling a lung cancer screening?
When I always think of and scheduling lung cancer screening, when that patient has made that decision they want to be screened, it's essential that we get them screened at that moment before they change their mind. They're ready to change. So when you're looking at your behavioral health changes, the decision when that patient and their healthcare provider had that discussion to get screened, that's a teachable moment. They want to improve their health. Get them in. There's no reason for someone to not be able to get screened within a week. You can, there are about 20-second scan with a patient navigator can help get them in. You can work them in at lunch. You can work them in before work. You could work them in after work. You could come play around with the schedule by going through a patient navigator. Make sure everything gets authorized and approved. But to get them in, just try to find the nurse navigator or patient navigator, nurse or whatever, and to enroll them and try to get them in at the closest imaging center close to home. Is that helpful?
Definitely is. And to touch on, you said very quick to get CT scans, very quick to get a screen. So from your experiences, what needs to be done to improve the system that already exists? I mean, you already touched on like it should be easy to get people in, but what are some of the things that we can do to improve that?
I think I see a lot of the barriers with the upper leadership, the senior leadership, who aren't quite invested in the program. And so if your senior leadership is not invested in the program, you're not going to get the resources. They don't see them as a value. When we talk about stigma, we always talk about, the stigma of public. But what I see is a stigma of upper leadership who may not see a value of the people who smoke. And so we need to change that perception, the perception of executive leaders for the lung cancer screening population that tends to be lower income, working class, and I mean, people smoke. I mean, it's an addiction. We need to break that stigma that anybody with the executive leaders and these healthcare administrators, to help with the implicit bias, to help get these programs the resources they need. You need to have a dedicated telephone number, because I'm sure you guys have tried to call these lung screening programs and you sit on hold for a long time, they transfer you. And sometimes the healthcare system doesn't know how to get a hold of the lung cancer screening program, or may not even know the lung cancer screening program exists. Those are system issues, so you should be, if someone gets a lung cancer screening in a healthcare system, there should be a point of contact. That is your patient navigator, and where you can call that dedicated telephone line. People don't want, and when they want to get screened, they don't want to call a number and wait on hold for about 5 minutes, then get transferred to someone else and then someone else. And then when you hang up, now you're like, how do I get hold of that person? They're going to get checked out and they will not come back. If they get, and you want to make sure with that patient navigator, and when they do get a hold of you, you give a direct line to them. If there's a billing issue, you want to make sure you tell them, because you'll do the assessment, you'll know if it's covered 100%. They need to have a direct line and say, if you get a bill on this scan, you call me, and we will take care of it, and give them the direct number. Just don't give them, like a lot of the hospitals give you a number that ends with 0000, your main hospital number. They're not going to know any of this stuff, and the patient gets lost and frustrated and they won't come back. So the key to increasing uptake is you need to get leadership to invest in the program. It is difficult to get the executive leaders on board, but you also need to get the people at the bottom in the community, and the survivors and everybody else to help come together and to support the lung cancer screening eligible population, saying we're standing with you. We need to get this, because if we can get this built up for the USPSTF population, and the programs are developed and you have the infrastructure in place, you can expand your program to cover people who are outside the guidelines where they can be safely screened. And so I know it's like people always want to say, well, lung cancer screening wouldn't have saved me. Well, it could have if we can, as a collective society, come together to encourage the healthcare executives. This is a priority. Let's get this program developed for the USPSTF population. So when you see it grow, quality and safety measures in place, now we're going to expand to other populations that are also lung screening eligible with some of the medical society guidelines. And then you can kind of open it up to more people, firefighters, occupational lung screening, people with a family history of lung cancer. So you can kind of open it up more, and you'll be invested, and more opportunities. But we have to get past that stigma. Also the stigma, lung cancer screening is hard. Lung cancer screening is complex. It's like people keep saying, we keep telling executive people in society, lung cancer screening is hard and complex, and so they don't even try. But when they start trying, they realize this is actually pretty easy. And so it's like, so when you say something like calculus is hard, no one's going to want to take calculus. Well, how do you know calculus is hard? You never took it. So we just have to kind of meet places where they are and just celebrate the small victories. You're not going to be up at the level of ILCAP in about 3 months. They've been doing it for 30 years. So that's their goal. But, just baby step it, and you're going to see the confidence and the boost. And you're going to see these small wins that are going to open up more opportunities.
Yeah, well, thank you so much, Michelle. I think you brought up so many important points in that answer. And one of the things that you mentioned is the importance of having a direct telephone line. And our team, we've been meeting with screening centers across the U.S., hoping to partner with them, because we have a lot of students, a lot of chapters across the U.S. doing the boots on the ground work and raising awareness about screening. So we do meet a lot of people who are eligible for screening. And so when we have these meetings, we've been able to see the whole array of screening centers and their systems. But it's really the screening centers that have dedicated patient navigators who have that direct telephone line that are able to take in the patient, do the shared decision making, submit the referral, connect with their PCP, and are able to take them through the entire process, that we found to be really effective. Because if the patient has to go to their PCP first to get the referral, then come back, or if there isn't communication between the PCP and the screening center, then it just opens up a lot of avenues for them to kind of fall through the cracks. And so just given that the screening rate for lung cancer is so low, I think that these programs that we call like one-stop shop, that have one-stop shop phone numbers, are so important. So I couldn't agree with you more on that. And also your point that lung cancer screening is so simple. It's even, it's pain-free, doesn't involve IV or injections for the most part. It's really all you have to do is lay on your back, hold your breath for a couple of seconds, and it's so much more faster and pain-free when compared to even mammography. Obviously, mammography is uncomfortable, colonoscopy, these other cancer screenings that have much higher screening rates than lung cancer. So I think you're absolutely right that I think people are just scared of lung cancer screening or don't even know how it's done. And so that's like what one of the biggest areas of focus is, just educating people that lung cancer screening is easy.
So I was just wondering, Michelle, so in addition to lung cancer screening, I think another important measure to take is smoking cessation. So what do you think is the best way to sort of implement smoking cessation alongside lung cancer screening?
Every aspect of the screening process is opportunities to provide support in the smoking cessation journey. It is a journey. It is an addiction. You have to be non-judgmental and meet people where they are and set health goals. So everyone can talk. So obviously when they talk to their primary care referring physician, they're going to talk about their smoking history and smoking cessation, encouraging them to quit or set health goals that will progress them toward quitting. When you do the intake, you're already doing the smoking history. When you're doing the smoking history, ask them, are you ready to quit? And and you could track that in your program on with your behavioral change, whatever the Prochaska model. You could do any type of behavioral change model, but you can assess readiness to change at each encounter. When you do a smoking history, ask them, are you ready to change? If they say they are, be ready to provide resources to help them quit. If they're not ready to quit, just say, you can always say when you're ready, just like, we're here to help you, and just continue to encourage them. And then when they come into the imaging center, and they get checked in and the tech brings them back, you can train the techs on how to also provide some coaching and encouragement, and letting them know, hey, if they're currently smoking, just kind of say, we have resources whenever you're ready to quit, and just be supportive. Meet them where they are. When you get the results back and you're reporting the patients back to the patient, you're going to provide some smoking cessation information in there as well. And you can talk to them and just say, this is the team's recommendations, and we're going to schedule your next scan, and you can set a health goal. That's what I did when I first started, and then the follow-up rate was going up. They were coming back for their scan, which is great. And also, I kind of took their mind off of what is this nodule going to do in the next 36 or 12 months, and said, well, during this time frame, what could we work on from a health perspective to make you healthier? And you can kind of use motivational interviewing skills to see if we can help them start thinking about health. We want them to quit smoking. That would be great, but if they're not ready, what else can they do? And then as they start thinking of health, they'll eventually, maybe on the next CT scan, that may be the time that they decide to quit, and they can kind of work on it and see if there's, and you can actually see some changes in the scans as they quit smoking. And so that can also be a goal to help them return. So let's work on this goal. Let's try to become healthier, quit smoking, or whatever their health goal was. And let's see how the scan improves, So it kind of gives them something to work on. They come back, complete the scan, and then when you give them the reminder call to come back and complete the next scan, you're going to update their smoking history again, see how well they're doing, and then asking them if they're ready to quit, or have they tried, if they need any other assistance. You don't want to push, you just want to be a collaborative partnership. and you'll build that relationship with these guys, and it could be that they're not ready to quit at that moment in time, but they have your direct line and say, if you need anything, if you have any symptoms between the scans, or anything, call us. And they will call you between their scans and say, hey, I'm ready to quit. Grab it. And just like when they're ready to scan them. Don't wait longer than a week before they change their mind. When they're ready to quit, get them enrolled in something. Don't give them a telephone number where they had to sit online for about 15 minutes to talk to a counselor. So you just kind of be ready to provide any type of resources.
Yeah, I agree that smoking cessation is such an integral aspect of like incorporating into lung cancer screening. And as you mentioned, like learning how to meet the patient where they are and providing all the unconditional support is so important as well. And switching gears a bit, I know that lung cancer screening is also like the only cancer that requires the shared decision-making process. So I was wondering if you could describe what the shared decision-making process is like for anyone who's unfamiliar with that.
Yeah, what shared decision making is, it's really a patient-centered approach. And and shared decision making is required for anything, for any procedure or anything that is ordered in the healthcare system. And so it's a discussion between a patient and a provider regarding their healthcare decisions. And I hope I may cause some controversy, but technically, lung cancer screening is not the only cancer screening that requires a shared decision making. All of it does. Now, where the misinformation is, it's the only cancer screening where providers can get reimbursed to do it if they document it. So if you document it, you can add 0.54 RVUs for talking to your patient for lung cancer screening. It does not have to be perfect. It could just be you talking, and because with lung cancer screening, you're not just looking at the lungs, you're looking at other parts. So you're just telling them, okay, we would like you to get this lung cancer screening, but I'm going to refer you to a higher quality program. But we're not going to just see the lung nodules. There's other organs in the chest. So you have to be aware that when you get this lung screening, we may call you back. We may tell you about some heart issues, some back issues, a gallbladder, a kidney. And so, there's other issues that can cause some concern and anxiety. And also, you're just telling them, it's important to come back because we need a comparison scan, but it doesn't have to be perfect, because they're going to refer them into a navigator who is going to progress that conversation to tell the specifics of the follow-up of that program. So it doesn't have to be perfect. You're just talking to them and just say, hey, I'd just like you to get enrolled in a lung cancer screening program if you're interested. So they know what's going to go on. They don't have, it's not a requirement. It is elective, so you're not being forced to do anything. But what I have realized since Medicare covered during MedCAC, Medicare required, they added the shared decision-making component to be reimbursable in order to provide a convenience to the primary care, to give them a chance to get reimbursed for it, to get RVUs. I talked to some from primary care today, and they have no idea that they could get RVUs for it. And it can be billed multiple times a year. But it's that discussion to encourage them. So if they talk to their patient during one of their wellness visits, just like they do with smoking, hey, well, I would encourage you to enroll in this lung cancer screening program. They may be ready to do it that time. They may not. That's fine. You had that discussion. You get your RVUs for that. And when they come back, maybe in 3 to 6 months, in that conversation, you just engage. It doesn't have to be long. It doesn't have to be 15 to 30 minutes. You're just being there for the patient because they may be scared. They may not be ready to do it. It gives them time to think, and then it's like your smoking cessation. It's health change. So they may not be ready to quit at that. They may not be ready to screen at that time, but you have them thinking about it. And so revisit it, and they can collect that those RVUs, and that's what and so it gives primary care opportunities to continue that conversation, but Medicare has given primary care physicians that opportunity to engage in conversation. It doesn't have to be complex. It's just a conversation between them and their patient. You're not going to get graded. You're just engaging in the conversation, and if they're interested in doing it, you're just going to refer them into a high quality program, screening centers of excellence, or and then that program can continue on the conversation to explain what the next steps are. That is not a one-time scan, and this is what to expect in our program. But it's like we just have to keep it simple. It's not a checkbox. You're not if you forgot one little section to talk about, you're not going to get dinged. You're just having that personal conversation between the patient and their doctor, and asking questions at their level, and then to help them feel comfortable and helping them in making that decision together. Is that helpful?
No, it certainly is. And kind of building off that, and a lot of what you said earlier is about having this like very open dialogue, having an open line that patients, people in general can call if they're trying to schedule a lung cancer screening. And obviously that initial scheduling of a lung cancer screening is so important, that initial step to actually make a screening. But so is, and like you mentioned, so is for people who meet the eligibility for lung cancer screening, so is getting annually screened or getting screened monthly. So a question that, to build off some of those previous things you've mentioned, how do we ensure that patients get lung cancer screening annually and not just that one initial time?
I'm a fan of patient navigators. Programs should invest in navigators with that direct line. When they have that direct line and you're enrolling them into the programs, Medicare in 2015, after they published that national coverage determination, Joseph Chen went out there and gave some webinar talks, and he said Medicare wants healthcare systems to support programs, not the CT scans, the programs. Lung cancer screening is not a CT scan, it's the entire process. And so and just kind of explain to the patient the program. And I kind of take responsibility for the programs for not bringing them back. So when they come in and you have people doing the intake to schedule the scan, you can tell them this is what the lung screening program is. We're looking for spots on your lungs for lung nodules. Most of us have them. They could be anything, but we're going to bring you back and we need to compare that to see if there's changes. That's what lung cancer screening is. With one scan, it doesn't mean anything. It just means you have spots. We need to bring you back at a certain time period to get a comparison scan. And they're all up to that. And another key way, what I have found, this is even before insurance coverage or anything, patients, you have to make sure that patients don't get billed. There's nationwide, people are getting billed their co-pays, and they're told, hey, come and get this free scan. And then they get a bill for about $1,000 or $300. It's like, hey, I thought this was free. You have to make sure, having that direct line to the program, if you get a bill, you call us. We will fix it, because they will get mad, and because hospitals will send them to collection, but they will get mad and they won't return. So you have to kind of open up, give them red carpet treatment. So when create a pleasant patient experience. When they come in, they are scared to death because it's lung cancer screening. And it's like, we are here along the way. If you know someone's scared, meet them out at the imaging center and be there to comfort them, and say, we're here. If it is detected, if a lung cancer is detected, it's early. They're asymptomatic with more options for a cure. And so we can help encourage them and provide support and hold their hand, and just be there and have that direct line. After they get scanned, don't let them wait a week for the results because they're nervous, especially if it's their first scan, or if they just got a Lung-RADS 4A or a Lung-RADS 3 and they're coming in for short interval. Don't let them wait a week to hear what happened to that nodule. Right when the results come back, try to let their doctors know, yes, it's stable. They can return back to 1 year because they're scared. Call them up and say, that everything's stable. We need you to come back. We want to see how these little guys go in a year, and this next year will be a free scan. So it's under their health plan that they paying on, and so you can kind of encourage them that way. So
Yeah, you said that really beautifully, Michelle. And it's been such an informative podcast. Like you said, just making the decision to get screened is a huge step forward, and it can be scary, especially if it's, your first time getting screening. And so what we try to do with ALCSI is, especially in Boston, is we try to meet community members, for example, at the T station, and we walk with them to the hospital and help them find the screening center, because even just navigating the hospital is hard if you're unfamiliar with it. And so we try to do whatever we can to make that process comfortable for them, easy. So I just really agree with everything you said. And our last question for you, Michelle, this has been wonderful, is just how can listeners get in contact with you if they'd like to reach out?
They can contact my email, michelle.ottersbach@gmail.com, and then I have my cell, which I can you can email me and I can give my cell if you're interested.
All right, well, it's truly been a pleasure and an honor to speak with you today, Michelle, and learn from all the knowledge that you have in the area of patient navigation. And we're just extremely grateful for all the great work that you've been doing and the perspective that you brought to the podcast. And to our listeners, thank you for joining us for this episode of the LC podcast. We hope you enjoyed it. Please keep an eye out for any upcoming podcasts or events, which will be posted on our website, www.lc.org. Thank you and have a great day, everyone.